Hi, and welcome back to April's Sisterhood in Surgery. Today, our topic is Call Vascular, leveraging colleagues around the world for input on challenging cases. Remember, this is a live show, so you can send in your questions to join by web. Go to pollev.com, text DeBakey, send in your question, or join by text. Text DeBakey to 37607, and we'll get your questions answered. Of course, we have my co-host Palma Shaw today, and we actually have an amazing panel of guests that are literally worldwide, so all over the world, and have their own amazing journey and just fascinating stories on how they got to where they are and how they've collaborated with vascular surgeons across the world. Palma, do you want to start the introductions?
My pleasure. It's really my pleasure to introduce Dr. Inez Torress. She is from Brazil. She completed her vascular surgical training at Hospital das Clínicas, part of the São Paulo University School of Medicine. She has dedicated the last 10 years to the management of vascular surgery emergencies. Her research interests lie in the technical skills training and the use of simulators, facilitating training of residents at her hospital in endovascular aneurysm repair and anastomotic techniques and limb angioplasty. Currently, she serves as part of the Global Training Task Force of the World Federation of Vascular Societies, where they've designed collaborative research projects to advance the vascular field. Additionally, she's active in the Vascular Surgery COVID-19 collaborative group that Dr. Wohlauer initiated, and she's resulted in 2 published papers and facilitated daily exchanges of information among her colleagues. She's particularly proud to have been selected by the Society for Vascular Surgery for the International Scholars Program in 2024, and this opportunity allowed her to connect with outstanding professionals, visit a prestigious hospital in Memphis, and attend the Vascular Annual Meeting, where she was honored to receive the 3rd prize for the International Poster Presentations. Welcome, Inez.
Thank you very much for this kind presentation and for the invitation. I'm very honored to be here.
Our next guest is Dr. Max Wohlauer, who's an associate professor of vascular surgery at the University of Colorado School of Medicine, medical director of surgical inpatient units at University of Colorado Hospital, medical director vascular lab, and associate program director of the Vascular Surgery Fellowship and Integrated Residency Program. He's the co-founder of the Vascular Surgery COVID-19 Collaborative Group, which was founded March 21st in 2020 to study the impact of COVID-19 on patients with vascular disease. He's completed a 2-year NIH Trauma Research Fellowship from 2009 to 2010 with Dr. Ernest Jean Moore at University of Colorado. He has a broad clinical practice, including management of chronic limb-threatening ischemia, diabetic foot amputation prevention, exertional leg pain, TOS, and other interests. Welcome.
Thank you. Glad to be here.
And finally, Dr. Nina Yhap, who is the first vascular and endovascular surgeon appointed at the Queen Elizabeth Hospital in Bridgetown, Barbados. She's the sole vascular surgeon serving a population of just over 250,000 persons on a small island with limited resources and public care. And since she's the only vascular surgeon and she's on call, she has an emergency that she has to attend to in about 15 minutes. So we're going to ask Nina to share a little bit about what prompted her to get advanced training and let her tell a bit about her story related to the Global Vascular Companionship Program. Welcome, Nina.
Thank you. Thank you so much, Palma and Linda. And thank you all so much for this amazing opportunity. And I'm sorry to have to go at some point. I finished general surgery training, so I'm a general surgeon by trade, and then went and did vascular and endovascular surgery in Melbourne, Australia for nearly 3 years. After I left, that's actually where I met Palma. I went to the VEITH in 2022, and just fate would have it that she and my former boss, Iman Bayat, out of Australia, had met and started talking about global vascular companionship. I'd finished my training by then, but I really had left Australia where there was such amazing technology, so many vascular surgeons on a unit, at least 5 at any given time. And then I came back to a world that was so vastly different. A small island, really no consumables. No one knew what a Castro Viejo was. It was a really, really difficult time. And I think when I went to VEITH and I met Palma, I think it was just the breath of fresh air that I needed. I had been back in Barbados for about 6 months by then, not really progressing in an endovascular program here, because I felt kind of stuck and alone. And then by meeting Palma, it just really opened up a whole network more on this hemisphere, because my bosses are obviously in Australia, quite a far distance away. LATAM and North America are far closer for us. And through really meeting Palma and really just getting into so many other networks and other surgeons at the touch of an email, and joining the Global Vascular Companionship Program and sort of helping other mentees come in, it has been completely practice changing. And I can say with great confidence, if I didn't have this opportunity to have a key in with Global Vascular Companionship, I for sure would not have been able to progress vascular surgery at the rate that we have done in Barbados. There's still a lot to be desired. Um, I want to really, gallop and run a marathon, but I know it has to sort of be slow and steady. Um, Probably the biggest thing that I'm most proud of achieving is that just January just gone, through an entire program and mission supported by the GVC, the Global Vascular Companionship Program. Iman Bayat from Australia came down here for about 2 weeks, and we did 11 cases. We did my first open elective AAA. I've done emergency AAAs. My first open elective AAA. Sorry about the noise. And many hybrid cases. I'd never done a hybrid case here. I just wasn't able to logistically get my hospital kind of to get that hybrid thought on board. And we did honestly a groundbreaking carotid body tumor case, which I'll get into a bit more. I guess, Palma, I've said a lot, so I just don't want to go off base. So you can redirect me if needed. But the GVC has changed vascular surgery starting out in Barbados, undoubtedly.
So Nina, can you just mention a little bit about the mission of the Global Vascular Companionship, and you're really the product of that, the original product of that program?
Yeah, it was a program that is, so the mission that came here had very clear objectives. Donation, so literally duffel bags came with consumables and equipment and instruments. I had one Castro here that was old and not great quality. I had no sheaths. I had no access needles. All of that was sponsored and donated completely by the Global Vascular Companionship Program. Above that, these were cases, I chose very particular cases that we actually could not get done in Barbados. It was, in terms of the carotid body tumor, we don't have advanced head and neck surgery or maxillary facial surgeons or even advanced neurosurgery here. We used to have a fairly robust medical aid scheme, which is like where we'd send patients overseas, even to America or Canada. That fund has essentially run dry over COVID. So our patients, if they're not able to afford through private health insurance to go overseas, realistically, they don't get the care that they need. And this was a case that I chose for my former boss to come and do with me if possible. Admittedly, it was a very unique case and probably not the forum for it to go into all the details, but it was a case that he and I had actually never really met exactly per se. But through Palma and through the GVC, within an hour and a half, we had spoken to Dr. Obara in Tokyo, Japan, Prem Gupta out of Hyderabad, India, Philip Cole, Clem Darling out of Albany, and then probably the final person with a lot of carotid body tumor experience was Alberto Munoz out of Bogota, Colombia. And within an hour and a half, we had a plan from the most experienced vascular surgeons that I could ever hope to even communicate with, far less have them answering my questions and helping me. And with all of these brilliant minds, along with, Palma as well was the spearhead for this. This was something that Iman and I said, I think we can do safely. We got my ICU team on board, and we successfully did our first carotid body tumor, which actually ended up to be a slightly different pathology. And she did exceedingly well. And it was such a groundbreaking case for here in Barbados. And I am just so eternally grateful for just anyone even bothering to answer an email from someone in Barbados. And I think through an established network like GVC, it does bring a lot of legitimacy to it. I'm not just an email in someone's inbox or someone's spam. You have a platform and you have help literally at the touch of an enter button. And Clem Darling, who has been a support to me in so many other ways, at the very end of his last email, he wrote, "We're all here with you." It was just, yeah, I get emotional. I'm so sorry. But he wrote, "Nina, we're all there with you." And it was just brilliant. So
He's just
sorry.
like, that's how Clem is, right? He's like
Yeah.
everybody's best friend. He's such
Oh, so lovely. And it gave me the confidence because Iman is like, "This is your case, Nina. I'm leaving in 2 weeks. This is you." And through Iman, through Palma, through Clem, through Alberto, everyone just virtually, and that brought gravitas to it because I presented that to my hospital board. I said, "This is not me doing cowboy surgery. This is legitimate. These are world-renowned vascular surgeons, and I think we can do this safely." And it brought a whole level of just progression for this program I'm trying to progress.
So I would say that just to mention that the World Federation is collaborating and supporting, which I'm the Secretary General, we're supporting the Global Vascular Companionship, whose goal is to match mentors with mentees. And they're trying to build this relationship of training and expand knowledge in underserved countries. And Nina's coming to present at the International Society for Women Vascular Surgeons. So I'm going to introduce her to all the women in Chicago at the end of the week. And she'll get to know more people there that maybe can help her mission, or maybe can go down there and help her out, if they have time off. And then she's going to collaborate because Max now opened his access for his, which you'll hear all about, his vascular collaborative in a minute. So she's just got lots of people to support her. She's not alone.
No, I think that's the key. And I mean, Matt and I were sort of on the pre-room before this webinar, and he's so kind of his first message was like, "Nina, give me your contact directly. I've added you," and it's hundreds of people. So it is such a huge community that you don't have to be living in the United States or somewhere really big like Australia to have such people who want to help, and just networking and through this media has changed practice for sure.
That's a great lead into Max giving a little bit of an introduction about how this all was born, this whole collaborative.
Great. Well, thanks for the opportunity. So the group chat started 5 years ago, March 21st, 2020. And I was messaging friends and colleagues in the US and around the world. We're all in the same place, trying to prepare for the unpreparable, this COVID pandemic that we knew very little about, and we all had to become masters extremely quickly. And I was sharing information with various people, and I decided to bring all those conversations into one group chat. And that's how it all started. I created a link where anyone who is a member of the group could invite others, and it erupted from there. Within 5 days, the group chat filled up. I didn't realize there was a maximum capacity on a group chat. It's 257 people, and there's no way to break that. So I started a second group chat when that filled up. And in its infancy, we were posting thousands of messages a day. I taught people how to take the alert system off because they were in the OR getting pinged, ping, 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 ping every time there was a message. So we silenced that. And it created a platform. It created a platform that was much needed during a very vulnerable and important time for us and our patients to come together and share information and do it in a very open and generous way. And we started kind of a informal code of conduct that when you posted, it was a thoughtful comment. It was something that you took a moment to prepare. People listened intently, and we had mutual respect for one another and for where we were coming from. And that allowed us, when we set that tone, to share and live through some very difficult experiences together throughout the pandemic. And we shared ideas ranging from what to do about PPE, how to protect each other, how to protect our family, and what to do taking care of patients. And we had conversations ranging from the mundane to the most challenging. And that's how it started.
And Inez, why don't you talk a little bit about how you got connected to that? And a little bit about your involvement with the Global Training Initiative.
First, congratulations, Nina. You're very brave. Very nice to hear your story. And Max, I'm very proud of being part of this great project you have started. I have met a friend at a conference years ago, actually in Germany. And when I visited her in Hamburg at the time, I met Harleen Sandhu, who invited me to visit Houston, where I met Rana Fifi, who is in the group. And that was my way inside of the VASC group, which was a very important experience, especially during the pandemic, where everybody was so isolated and didn't know what was happening. So even before I saw my first COVID case in Brazil, I had heard a lot of the experience abroad, because the first wave had already started in New York, Italy, and we had people from everywhere. So even before I saw the first patient here, we could hear how people were dealing with outpatient clinic, how telemedicine was getting better, how severe were limb ischemia in those patients. And although it was hard for everybody, I think having those information made us less stressed, maybe, and we felt more comfortable knowing that we could share and make questions about things that were new for everybody at a time of a lot of stress. So that's how I entered a VASC group. And for the World Federation of Vascular Society, I joined this group after meeting Palma at a conference, totally by chance, actually at an ESVS meeting years ago. She's a very open and nice person. After we met at the conference, she invited me for a dinner, and then suddenly I was invited to this global training initiative. It's a very nice opportunity again to connect people really from the entire world at a monthly basis. So every month we have a meeting where we can discuss how we train our residents, our trainees, how our hospitals work, and we can really share very nice and very important information with people from all around the globe.
COVID was very isolating, so we forget that probably because it's been a couple years, but I'm sure this collaborative group, you felt less isolated. You had somebody to talk to or somebody to vent to when maybe you were separated from your family because you were in contact with COVID or on call or in a hotel room. So it probably helped us as a group, emotionally and mentally too. So thank you for all of y'all's work. Has it changed?
Absolutely.
Go ahead.
Go ahead.
No, I was going to ask, has it changed how you practice now, having done that, and like who you talk to and who do you ask advice from?
Yeah, so I want to acknowledge there are so many people on the group, and I made it clear from the beginning that it's really the group members that are the lifeline and that deserve the recognition for the group, the contributions, the active listening. And I do want to especially acknowledge Rana Fifi that Inez mentioned early on. Rana has an amazing ability to connect people, and she knows so many people on every continent, in every state. And she really, in the early days, really accelerated the growth of the group, and I'm really grateful for that. So we created this, community where it was a safe place to be vulnerable. We could agree to disagree. We could have some very challenging conversations, And that also allowed us to vent and offer peer support. And then after the pandemic, I've had people reach out or comment on the group how grateful or how important that's been, is that they had a place to share ideas and be, am I the only one that's quarantining in the basement and staying away from my family and young kids? It's really isolating. And then other people would say, I share that. I feel ya. And here's some ideas. Here's a wand that you can try to decontaminate your clothes when you come in, or have a pair of, shoes that you leave outside. People had all sorts of ideas of how to cope and how to shift on the fly. And so, yeah.
But the nice thing is that the stuff gets posted like, hey, have you seen the latest article on the following? So it's not just about people giving their opinion about how they do things. It's people that are knowledgeable and that actually really are well known for their back in this particular venue, and they have data behind the information that they're sharing, which I think is really nice.
Yeah, we learned, one thing we learned was to phone a friend. There are friends all over the world. By having a platform that's international, even if you're going into a case on call and it's a really complex scenario, there's somebody who's awake. It's the middle of the day, or they're in between cases somewhere. And so that's been really valuable. Thinking outside the box. So during COVID, we had to do that all the time. And now that we're post-pandemic, the group chat shifted to, case presentations and commenting on them, getting some real-time advice, or general comments about the world of vascular surgery. And we developed protocols through this. We studied what we learned rather than it being, a single anecdote here or there, that we're bringing our data together and analyzing it. And taught us not to live by dogma. Challenge yourself when you're tempted to say, this is how we've always done it. Then we learn from somebody who does it differently and does it really well. And that healthy challenge is really good for all of us to grow. I think it taught us to support each other and kind of have a relentless push across the finish line. We were in a day in and day out. This was really a mass casualty incident that spanned borders, oceans, mountains, and it was grueling. We'd wake up and get some fresh air and have to go back in and do it all over again. Sometimes we didn't even have that fresh air. We're quarantined and isolated. So that optimism and relentless push across the finish line, I think, is something that we all learned during the pandemic.
Max, do you know if the collaborative has how percentage of academic versus private practice surgeons? Because, that's another thing, is it probably brought, we've traditionally been very separated, right? Like academics versus private practice. And, but that I feel like would totally bring everyone together. And especially now that it's moved towards case presentations, it must be really gratifying for both sides to hear how a private practice surgeon would do it, how a big hospital center would do it, et cetera.
Right. I was going through the kind of the early days. So the first post was, I created this forum for vascular surgeons managing COVID-19 pandemic to share ideas, problems, and solutions, and then welcoming people to the group. And then someone commented, there's a lot of bigwigs on this group, I'm intimidated. And then the so-called bigwigs said, it's not about that. The pandemic is the great leveler. There's no titles, there's no bigwigs. We're all here together. We're all on the same playing field. And whether you were somebody, a big name giving a big podium presentation at a national or international meeting, or a trainee or a junior partner, spanning the whole spectrum. We had large group practices. We had people in single private practice that were all there together and all had knowledge to share. And that was that we're all doing the heavy lifting. We're all there taking care of patients, and innovating is what brought us together. And I think that's a great call out, Linda.
And how do you think the different platforms, for example, there are people that post their pictures in the OR and their outcomes on Twitter or on Instagram. And I think that the WhatsApp chat that you've developed is really very different. I think, would it not be much more confidential?
Yeah, so, WhatsApp is a secure messaging service. It's encrypted. And so when exploring different social media platforms, there's, an opportunity in different flavors. So there's some larger social media platforms that have, hundreds of millions of active users. There are some other platforms that are smaller. And what worked on WhatsApp was that it was secure and encrypted and also kind of the right size to have a conversation. It wasn't too big that people started talking over each other. You could talk in real time. And it wasn't too small that you're kind of talking to your own inner circle.
Inez, do you think you said you published 2 papers in working with the collaboration? Can you explain a little bit about how that went about, or how that developed?
Yes, I think Max was saying very interesting things about the group, because it's very actually intimidating, because you're there with very big names in vascular surgery. But nonetheless, I think Max can maintain a very friendly environment where everybody feel free to communicate and express ideas independently of this academic degree. And with that, he can really get everybody to collaborate and create nice things out of it. One of the papers I remember when it started back then in 2020, and I was having difficulty putting my data inside a protocol that was going on in the group. And then Max just made a video conference with me so we could adapt my reality with the research going on. And with that video conference, I just had an idea for this second paper that we just ended up writing together. So this is a group that really can bring nice information and start a very interesting collaboration, joining people from different academic degrees, different countries, different places, and bringing important information for us every day. And also lots of different opportunities. Like I work with injuries and trauma, and we were just discussing about that today in the group, about how many patients you should be able to have at the same time at a level 1 trauma center. So this group really evolved after COVID, and even today, when this is not a problem anymore, we have interesting things and new plans going on every week and every day. So it's a very nice and very collaborative form of conducting the group.
Can you think of a clinical case or a patient you took care of that you reached out for some international collaboration and it influenced your approach to the case, or it may have helped you avoid a complication? Can you think of a specific case that might have been?
Nina talked about a carotid body tumor, which makes you feel so grateful for what you have around you. Like, every day you complain, oh, I need more OR time, I need more tools, I need, more money to buy, and then, like what she's working with is it's just really humbling.
I'll add on that on the topic of carotid body tumors. So Carlos Hinojosa, Professor Hinojosa from Mexico City, is one of our members and who I met through the group chat. And he came to Colorado recently to be our international visiting professor. And one of my colleagues at a sister hospital happened to be doing a carotid body tumor case while he was in town. And, they're not frequent occurrences, even where they're more common. And he's got an innovative and very successful technique with great outcomes. And so we went over there and shadowed, and he was available to answer questions in real time, very useful, helpful to the team doing the case, and the patient had a great outcome. So if we can do it for carotid body tumors, we can do it for just about anything.
Mm-hmm.
Now, and through the different interactions, have you sensed a different practice pattern in the US versus Asia versus different parts of the world? You know, everybody has their own way of approaching things. Maybe Brazil versus the US?
I'd love to hear Inez and Nina comment on that one.
It'd be perfect to on Asia and the US, to be very honest with you, just because I don't have any experience in either of those regions. In Australia, I try to mirror the practice as much as possible. I don't have a vascular governing body. We have a Caribbean Vascular Society, very small. There's only 4 Caribbean vascular surgeons in 23 territories. So when I say we have a society, it's basically a WhatsApp group. And 3 of us actually were trained in Australia, so we practice very similarly. And they're actually, Clem Darling has a lot of Trinidadian fellows that come, and also in the US, who are upskilling in vascular as well. So it's hard for me to comment on, Asia versus US kind of practice per se, but we tend to mirror where we were trained in Australia.
Nina, you mentioned the permacath or temporary. So I'm always so interested because we do a lot of dialysis access, and this is sort of off topic, but since we have you, how does that work in the Caribbean? So I mean, how do they get dialysis? It's only if they have cash to pay for it, or?
No, so our system is completely government funded, a completely free healthcare system. Completely. It's a socialized healthcare system, which has its amazing pros, but it's very difficult disadvantages. Barbados has a very high middle class socioeconomic sort of demographic, but no one really has private health insurance. So everyone relies on this hospital where I am working, and almost everyone in the island is a public hospitalist. Private care, there is private care, but it's not vast. And it's very unique to have a solely private practice. So all of us are essentially public surgeons. Permcast, we have 5 dialysis machines, 5.
Wow.
And we have 30%, 30, I don't want to quote it wrong because our nephrologist, we have one of every specialist essentially, 1 neurosurgeon, 1 plastics, 1 vascular, 1 nephrologist. And our nephrologist recently produced a paper that 30% of people over the age, so I don't want to say it wrong, but 60, over the age of 60 are on dialysis. We have a huge dialysis population. To be honest, when I came back, I'm actually dealing with more dialysis complications, central venous stenosis. That's what one of my colleagues from Iman, from GV, some Global Vascular Companionship, we did quite a lot of venoplasties because of just complications of long-term use of perm calves because we don't have enough fistulas being made. Now myself and a renal transplant surgeon do all the native fistulas, and I do the redos or grafts, and I try to maintain their accesses through central venous, preservation. But dialysis has been something that I have not thought would be such a huge part of my practice, but because of the need has become probably I'd say a good 40% of what I do. The rest of me being critical limb.
That's amazing. And, they go 2 and 2. They go hand in hand, usually. So, wow, that's incredible. Is it from diabetes, high blood pressure, or?
Yeah, we have a terrible high rate of diabetes, a hypertension, a hypercholesterolemia in Barbados. There's actually a study going on about the genetics of it in the Black Barbadian population. We have such bad tibial disease. It's not iliacs, it's not FEM, it's not POP, it's triple vessel tibial disease. And very different than what I was really looking at in Australia. We were doing a lot more FEM POP disease. But here it is really unique. It's really stubborn disease. We have a very high rate of major limb amputations because we had no way to revascularize them before. Trying to revascularize as many as possible with when we can do endo. A lot of them are not bypass candidates because there's no target. It's really, really complex and difficult disease.
Yeah.
Early on in our conversations, one of the first conversations we had during COVID was about COVID line teams and who was going to place the dialysis catheters in at various hospitals. It was either the anesthesiologist, sometimes it was vascular surgeons included in the group. And that's such an important skill, and maintaining that as vascular surgeons as part of our armamentarium. So kudos to you for providing that for an entire country.
Yeah.
And in all fairness, the nephrologist does put them as well. But like this gentleman I'm going to do shortly, we're going to lose the perm cast site that he's at. So I'm going to put in a perm cast on the contralateral, which is virgin at this time. But I agree with you. When I was away, I was looking so much at aortic and peripheral and, even central vein work. Dialysis by force, I've had to upskill and kind of MacGyver, to be very honest with you, different things, because there's disease I haven't encountered before. And I'll often ask the group that Palma's and I are part of, but you kind of, you think you've seen a lot. I know I haven't seen everything. I see something new every week, but when you get into the hot frying pan, you really have to pivot and come up with something. And that's the reality of sort of being in a resource poor situation like this.
Mm-hmm.
And we talked about what we've learned from each other, and I've learned a lot from Inez, from her surgical innovation, her interest in surgical education. We've talked a lot about that on the chat. And then managing patients with chronic limb-threatening ischemia as well as acute limb ischemia. So the article that she has in press, is taking care of almost 300 patients with acute limb ischemia during a less than 3-year time period. And we had extensive conversations about managing chronic limb-threatening ischemia, given the shortage of access to surgeons and operating theaters, the way that she manages a very large population of patients with CLTI, and how we applied that. And I personally applied that to the patients that I was surveilling during COVID, because we didn't have an operating room.
Mm-hmm.
I'm competing against the entire general surgery and surgical specialty service lines for an operating room. And so a patient with a wound, how do you manage them? How do you prevent an amputation? And she offered tremendous insight on that.
So when you get this advice from peers, do you ever think there might be a chance that you might over-rely on that? Or how do you kind of, I know you want to value everybody's input, but you still have to consider it, right? I mean, you have to consider how advice from an Asian part of the world or the Southern Hemisphere may differ, and the patient disease might differ than what we have in front of you.
That's for me. Sorry, Palma, is that right? Sorry.
Anybody. You get
sorry.
information from
Inez, you want to
parts of the
go ahead,
world, and now you're bringing it back. I mean, what you did in Australia is different than what you can really do in Barbados, and the disease might be different.
Yeah,
Totally. Sorry, Inez, no, please go.
Yeah, I think even inside the country, you face completely different realities. In Brazil, we have public and private system. I work for the public. I think almost 25% of Brazilian population rely on public system, and we also have private system. It is a completely different reality in terms of resources and material. Most of the published papers and advice come from developed countries, and you have to really think a lot in what you can apply and how you can apply the things you read and the advices you have. In my hospital, I'm absolutely sure inside the public system that the ischemia time is the great problem we have today. That's what we're trying to fight and reduce by advising what kind of patient should get to us faster, because our ischemia time was up to 2 days for chronic limb-threatening ischemia, actually for acute limb ischemia. And then that's absolutely not acceptable. It was even higher during the pandemic, but that was everywhere. But prior to the pandemic, our time was already very, very high. So everything you see and discuss and talk, you have to really think what fit your reality, because they are all very to discuss if we should have penumbra or another material is very important, but something much more simple has to come first. So I think all discussions are valuable, and sometimes you don't even realize that's the problem before you talk to somebody or you visit somebody from another place. You're so worried with, oh, but we don't have drug-coated balloon, we don't have penumbra, we don't have materials like this or like that. And when you stop and look at your data, you realize that that's not the real problem yet. So, but all this conclusion come after seeing other realities and talking and looking at your data and discussing it. So, although the realities are completely different and a lot of things may not apply, I think all these discussions open our mind to see and realize where the problem is.
We have a question from the audience. Since there are pros and cons to both public and private hospitals, are there, and I'm assuming this means, just public maybe not having as many resources, can you think of some cases that would be worth traveling for or sending out?
In Brazil?
Brazil, Barbados, I mean, both countries. That's a hard question.
I think it really depends. For the public system, we, in theory, we have the resources to manage all kinds of situations here in Brazil, from leukemia to thoracoabdominal aneurysms to, we have all the resources. In general, the problem is how many patients are waiting and how much time they wait before they can undergo a procedure at the public system. Oh, I had to leave.
Oh.
So I think Nina had to leave.
Yeah.
She should have to.
That's okay. Continue.
So for the public system, I think we have an organized system with hospitals ready to do all kinds of procedures. You don't really have to send this patient to another country. The same thing for the private system. The real problem is inside the public system, the patients have to wait sometimes for years before they can really get a procedure done.
Wow. Who triages that? Is that you, the physician, or who decides on what is urgent, what can wait?
Yes. Inside my hospital, for example, we are a tertiary hospital, a public hospital that sees all kinds of complex cases. So we have a group that discusses carotid, aneurysms, limb ischemia, and we have a waiting list based on the patient's risks, defined by how long they are waiting, how large the aneurysm is, and things like that. It's basically a decision of the group, carotid group, aneurysms group. Sometimes we have a meeting with all the staff to work and discuss this kind of situation. But basically, it's the time they're waiting, and for aneurysm, for example, their size.
That's
Because
amazing.
it's just interesting when you think about the global vascular guidelines. There was a collaboration published in 2018 online and 2019 in print. It was really a Society for Vascular Surgery of the Northern Hemisphere the European Society and all of Europe, and then the collaboration with the World Federation of Vascular Societies and representatives. And the reason the World Federation was so important that they were involved in this, to give their perspective, is for exactly what Inez is saying, because you can't just say the US and Europe, well, this is what you should be doing, and you're wrong if you don't do it the way we do it, because there's so much else going on out there in the world, availability of devices, cost, expense, lack of transportation, and different things that have to be considered when you make your recommendations about how to manage something. So I think it's important.
Yeah, all these factors that we don't think about here.
So what do you think is going to happen in the future, Max? Do you think this is just going to keep ongoing with the WhatsApp chat, or, I mean, how do you see it evolving? It seems to be just thriving.
Yeah, I mean, when we started 5 years ago, had no expectations of that we'd still be going strong 5 years later. It's a testament to the members and really to the vascular community. You know, we do amazing work around the world. We're taking care of patients. We're, you know, earnest about it. We really mean well. We want to take comprehensive care of our patients, and people are taking the time to talk through cases and support each other. And, you know, as COVID taught us, you could be, you know, 3 miles away or 3,000 miles away and feel just as connected. So let's keep it going.
Do you have a younger crowd joining more now?
So so the group chat is open to any vascular surgeon or trainee that wants to apply. And anyone that's on the webinar or listens later, reach out to myself or to Palma or Linda, and we'll add you into a chat. And if the chat fills up like we did last time, we'll start a new one. So it's really a way to take the information that we have at our fingertips and share it. And that generosity that started early on in the pandemic, we're sharing protocols, algorithms, how we're managing patients with DVTs who are COVID positive. A story about a vascular surgeon in France who deployed a unit to go to the surgical wards and do everything they could to prevent their post-op patients from getting intubated, because they saw such a high mortality when patients were intubated during the pandemic, you know, and the heroism that related to that. And so we have this information, and having a platform to make the most of it, to share it with everybody and all of those who are interested and engaged. That's the idea.
I mean, I would think you would still need to, if you have a case and you present it and somebody presents how they would approach it, I would say you would still need to really think in the context of where you are in your hospital, what resources you have to manage that specific entity. Can you really manage that patient? Because I think you could try to manage the patient, and if something bad happens, you can't defend that. To say, oh, I checked with the WhatsApp chat, and they seem to think it was a good idea. You know, I mean,
that's a great call out. It's similar to having a conversation at the water cooler at a meeting with a group of colleagues. So this is informal, hypothetical advice. It's not legally binding. You take it or leave it. People are giving genuine, offering suggestions of how one might manage a situation or a scenario, and offering some outside of the box options for people that are in a tough spot and wanting that brainstorm. It's not a formal consult by any means.
We have a question from the audience, which is going to be a nice sort of lead. We have 10 minutes left, so this will be good for a positive ending. Can you think of anything implemented because of the pandemic that made things better for the patient? Some protocols, like you mentioned earlier.
I'm going to go first, Inez, or Palma, or Linda.
Well, I just think it's why we're here, right? This rapid communication, and I love the fact that, it's 10 at night here, but it's 10 a.m. in Japan, right? So, you can reach out to your colleagues. And I feel like the networking that we've done through the World Federation and the Global Vascular Companionship and the Global Training Initiative and the different collaborations between the different societies, the SVS, the ESVS, I think these relationships are just exponential. I think I think 5 years from now, it's not even going to look the same. I think it's good. And with AI, who even knows what's going to go on? It's just, it could be an explosion. We won't even recognize today, 5 years from now, the way we communicate and process the data for the patients.
I think just the fact, like the examples that y'all gave, I mean, even before the show started airing of, this, Nina's going to give this talk next week. And she met you and now she's giving a talk and then she might not know somebody. I mean, it just increases, like we talked about, our networking, but also what we're learning from each other on national platforms. I mean, it makes it interesting. I know diversity is like, I don't know even what's happening with diversity nowadays, but I mean, it's different now than it was even 10 years ago it's always the same speakers talking, right? 10 years ago, the same people. And now you're seeing new faces, in new international faces, and what they have to say. I mean, it's just really eye-opening, the fact that Nina's like the only person on call, and here I am complaining about taking too much call. I mean, it's just, it makes you feel very, now I feel like I'm, I complain too much because like she's just living life and loving what she does, and I mean, it's got to be hard day in and day out to do that. And I mean, a whole list of AAAs that you have to get to and carotids. I mean, my fellows would it would go over there because here in the U.S., as you know, at being program directors, the open aortic number is just like declining. But so it's so good to hear what everyone else, like what their reality is.
Well, there are going to be even opportunities for research. So we're going to open an international research fellowship with Methodist under the guise of the World Federation through Alan Lumsden. And then there's going to be a clinically based Tokyo fellowship that someone can go under the auspices of the World Federation, but to go to Tokyo and spend 6 months there training and learning the way the Japanese are doing things, and they can actually scrub. So these are just all new things that are coming along that I think we're going to be able to use to our advantage.
Yeah, it's a great opportunity to celebrate all the amazing things that we're doing as vascular surgeons around the world, and we can share them with each other. One of the things that came out of the pandemic, nothing beats face-to-face communication. When that's not available, having an option a virtual option for patients and for us to interact is a good alternative when face-to-face is not an option. And it also opens up doors to meet people we wouldn't have otherwise met if only face-to-face, if that was the only way we were meeting people.
And we're a small specialty. There are only so many vascular surgeons. So more than ever, we have to support each other. None of this, competitiveness and such. We all serve the patients and are looking for the best outcomes of the patients. So it's better to help each other, either online or in person or through presentations or scientific discoveries that you've made. We're all working the same.
Well, this is just an example. I mean, Max, were there any other specialties that created something like this during COVID?
I'm sure there were. I think the idea of sharing ideas when we needed to, when we're up against the wall, I think probably occurred to others as well. I think what worked really well and what continues to work really well for us as vascular surgeons is we're a small enough specialty that it feels like a family, we're a community, and we're big enough that we have, if you need to refer a patient to anywhere in your respective country or around the world, you're a few degrees of separation from being able to do that. So we're large enough to be able to offer that.
Yeah, that's a good point.
Inez, do you have any last thoughts or comments?
A very interesting things, I think, from this group is we had the opportunity to communicate online, and when everybody was isolated, but the World Federation and also the VASC groups, we also had a lot of opportunity of actually meeting in person, what I think was a very interesting experience, and maybe we could meet people and talk more freely about interests in common, sometimes very different ones, like I do some aneurysm 3D printing, and I found some people from Australia inside the group, and we could really share very specific tips about that skill. So it was very nice to have this connection online, but also very interesting to meet those people after the pandemic in Chicago, for example, or other conferences. Maybe the group still so interesting because it's not just the online, but also research projects, meeting in conference, finding people from everywhere with very specific things in common that can add to each other and really help us grow in whatever we're doing.
That's great. Well, thank you so much for joining. I know it's different times where everybody is, and what time is it in Barbados? I mean, Nina's operating. I mean, that's so.
I think it's an hour ahead of us. It's an hour ahead of New York.
Okay, yeah.
Inez, you're an hour ahead of New York, right? You're
8 p.m. here.
Oh,
Yeah.
wow, yeah. Colorado's 2 hours behind, right? Central.
It's almost 5 p.m. here.
Yeah. Well, thank you for your time. It's very precious, so we really appreciate it, and we hope that our audience has enjoyed, and will enjoy the ones that are going to watch later, everything that we talked about, and hope that motivates people to join the group chat and give us their ideas and, actively listen.
And thanks for all you're doing. Really amazing, amazing work. And so great to know you both.
Thank you for having us.
We're actually really honored. Have a good day.
Have a good night.
Bye-bye.